Good afternoon. Welcome to another edition of the UCSF Medical Grand Rounds. I'm Bob Wachter. I'm chair of the Department of Medicine here at UCSF. Welcome to our live audience from our department, our colleagues here at UCSF, our friends at our partner sites, and folks within the UCSF Health Network. We already have about 300 or 400 people watching, and as is our tradition, we will post this tonight at about 7 p.m. on YouTube. And so far, we've had about 250,000 people have watched the 10 or so grand rounds that we've done in this series. A few ground rules for our participants are listed here on the screen. The main one is put your Zoom window in full screen mode and then fit to window. If you have questions for any of our speakers, type them into the Q&A box at the bottom of our screen, and my colleague Quinny Cheng is monitoring them and will feed to us the most popular questions or ones that seem particularly interesting. We'll get to as many as we can. This is a somber week here as we think about the state of COVID. As everybody knows, we hit 100,000 deaths yesterday in the United States, which is really shocking and quite remarkable. I've shown on Twitter the picture of the University of Michigan football stadium full. That has 100,000 people and gives you a sense of the scope. So too does it think about certain cities. For those of us who live here in California, that's the size of the city of San Mateo. That's the size of the city of Burbank. My parents live in Boca Raton, Florida, which has 100,000 people, and my older son went to school in Ann Arbor, Michigan, which also has 100,000 people. So take away any of those cities, and that's a sense of the scale of what we've been experiencing. Today our Grand Rounds will be in 3 segments. The first one, we will discuss the experience of older people in the pandemic who have been disproportionately hit by the epidemic, and some of the most profound tragedies we've seen have involved older people, and particularly those in nursing homes and other congregate living facilities. Even for those that have not fallen ill, the epidemic has taken a huge toll in terms of loneliness and isolation and financial hardships, and probably the feeling of being cast aside by a youth-oriented culture. And so we'll talk about all of those things with 3 expert panelists, all UCSF faculty members. One, Louise Aronson, a geriatrician and the author of the 2019 best-selling book, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. And I believe it was last week it was announced that that was a finalist for the Pulitzer Prize in General Nonfiction. Carla Perissinotto is another geriatrician here at UCSF. She is the Associate Chief for Clinical Programs and a renowned expert on loneliness in older people. And the last will be Charlene Harrington, who's Professor Emeritus in the Department of Social and Behavioral Sciences. Charlene is a nurse and a PhD by training. Her major interest is in nursing home quality and regulation. She served on several key national commissions for the Institute of Medicine, now the National Academy of Medicine, that led to some of the most important regulations that impact the way we organize nursing homes. So that'll be the first half hour. We will have a panel discussion with those 3 experts. The next half hour will be a discussion with Antonio Gomez, who leads our critical care programs at San Francisco General Hospital. Zuckerberg San Francisco General is taking care of a number of ICU patients and has had actually remarkably good outcomes, far better than those reported in many of the reports that have come out in the literature. So Antonius will tell us what they've been doing and what seems to have been working in their care of critically ill patients at Zuckerberg San Francisco General. Finally, the issue of testing has gotten hotter and hotter over the last few weeks and much more confusing. I first brought Chaz Langelier on a couple of months ago, and we talked, I believe, about these new viral tests that were coming online, and there were a couple of them, and we were trying to figure out what worked. Since then, now there is a profusion of viral tests and now antibody tests, and they all have different characteristics and false positives and negatives and combinations that are confusing. And if you're anything like me, your friends and family calls, which used to be, can I get on the airplane? Can I go shopping? Can I touch the mail? Have now become, my daughter just got back a positive test and then a negative test, and now it's a positive test, and how do you sort that out? So I don't know the answer to that, so that's why we're bringing Chaz back to talk about some of the challenges and controversies in testing. So this whole session will go for 90 minutes, roughly 30-ish minutes for each of the 3 parts. Let's start with our panel discussion on the experience of older people in the pandemic. So again, Louise Aronson, Charlene Harrington, and Carla Perissinotto are our three guests. So let's bring them on. Here they are. One more. Hi, everybody. We can get rid of the slide and go to full view. There we go. Okay, terrific. Welcome all. Thank you for being here. Let me start with Louise. And here's a question in 20 words or less, Louise. Sum up the experience of being an older person in the United States, and then tell us about what the particular experience has been in the face of the COVID pandemic. You can have a couple of minutes for that.
Okay, good. Brevity isn't really my strong point, but
do what you can.
So I think for most people, it's an experience of decline in status, often combined with an increase in happiness and life satisfaction that is largely disregarded by others. And that does come hand in hand with much more popular physical declines, which are indeed disappointing. When we think of COVID, I think this has really brought to the fore all the ways people think about aging. One of the biggest things that I tried to tackle in elderhood was not thinking about aging as a monolithic category, particularly here in the Bay Area, where we often see, older adults being age 50 and above. That's a lot of us here, actually 3 of the 4 are on this current panel. So that is a
I turned 50 last year, so yeah.
Yeah, you and me both. We got Carla, though, right, standing up for the youth. But we tend to speak of older people as a monolith. And I think the fact that there has been so much death in nursing homes has contributed to the notion that all older adults are frail. Whereas in fact, if we're saying risk increases at age 60, and our oldest patients in geriatrics tend to be well into their hundreds. The oldest person in the United States right now is 114. So we're talking about over a half a century of human life. That cannot be boiled down into a single term. And the fact that we don't have language for it makes it worse. Look at deaths in California. Yes, about 40% of them have been in skilled nursing, but about 80% of deaths have been among older people. And that means a lot of them aren't in skilled nursing. To say nothing of the impact of the pandemic and our response to the pandemic on older lives. Carla actually said yesterday on Geriatrics Grand Rounds how some of our most homebound people, it hasn't been a huge change. What it's been a huge change for is all the very active people who are obeying public health dictates, unlike maybe some of the people running the country, for example. But many older people are actually staying home and wearing masks, and their lives have been impoverished. And some people think their lives are already impoverished, but they're not. And we are seeing in clinic, every day, the distress, the physical and cognitive declines as a result of that. So the great thing is there's so much more we know how to do. We have a huge evidence base. If we would apply it, we'd have a much better world in which to grow old.
One more question for you, then I'll move to the others. Early on, you began to hear a little bit of a theme that it's not so bad because it only kills older people, sort of a discounting of the lives of older people. So when you began to hear that narrative, first of all, were you surprised? And second of all, how did you react to it?
Not surprised, sadly, endlessly disappointed. I guess I find ageism to be a particularly curious prejudice because it's the only one where, other than like internalized prejudices, which are somewhat common, but not very common. Usually our biases are against people in groups to which we will never belong. But ageism is basically a bias against your future self. It's also a bias against people we all purport to love most, our parents, our teachers, our grandparents. So it's really illogical. I guess its persistence on and off throughout human history suggests there's some reason for that. I think it's more exciting to be a kid and look to be the most powerful segment of society than to be an adult and look toward frailty. But I think we have to realize that a frail person is so much more than a frail person, and you don't become frail overnight. I think even as a young person, I thought I would probably be 35 until one day I was 75, and that's actually not how it works. So most of being an older person is not about being frail. And yet when we distance ourselves from older people, we set ourselves up for the very negative parts of old age that are making us distance ourselves. Like it's just this logical, circuitous logic that harms almost all of us, except for the people who have the greater misfortune of dying young.
Yeah. All right. Well, thank you. Carla, a sort of similarly difficult question. One of the things you've studied is loneliness in the elderly. So tell us a little bit, just a little primer on loneliness in the elderly, and then apply it to the current predicament.
Sure. So loneliness is really the subjective feeling of being alone, and it can go hand in hand, but separately from social isolation, which is really a quantifiable measure of the number of connections that someone has. What's interesting is that there has been emerging research, some of my own, in the decades before COVID, really highlighting the health effects of loneliness and isolation in terms of drastic increased risk of death of all causes, cardiovascular death, increased risk of cognitive impairment and loss of independence. All these things which are actually what matter the most to all of us as we get older, which is maintaining our independence and our mind. Fascinatingly, also on February 27th, right as the pandemic was taking hold here in the United States, the National Academy of Sciences released the consensus statement on the health effects of loneliness and isolation and the role of health systems in terms of identifying loneliness and isolation, their risk factors, and way to mitigate it. And now fast forward into COVID and shelter in place, we're faced in this situation where we know that loneliness and isolation both together and independently affect health, yet we were forced into a situation where we had to physically distance ourselves and isolate ourselves to protect our health in the now without understanding the long-term consequences. So where we are now is really knowing that there's these health risks, and we do not know how long it'll take to have negative health consequences by forcing this isolation and potentially increasing loneliness. I can tell you also that my colleague, Dr. Ashwin Kotwal, and I are in the midst of a study in the Bay Area understanding how COVID has affected older adults in terms of their loneliness and isolation and access to services. And what we found there are really some interesting trajectories that about 40% of people are experiencing a worsening of their loneliness specifically. There is a smaller percentage of people that are staying about the same, and then there's a very small percentage that are actually having an improvement, because I think we're seeing an outreach to older people in a way that didn't happen before. What we don't know is how long will this sustain? What happens to the people that now have outreach, and after this is over, will they go back to being ignored? Or is this an opportunity for all of us to learn a little bit more and recognize that older adults are our future ourselves, or they are ourselves, and we can't continue to ignore.
So this massive conundrum that loneliness is terrible just as a feeling and also has bad health outcomes, and yet the isolation, particularly for the elderly, is a sound kind of public health maneuver, in part because they're the group that's at highest risk. So one of the sort of solutions has been electronic ways of communicating with people. How has that gone?
Yeah, so great question, Bob. And what's fascinating is that is the go-to for everyone, is that, everyone is Zoomed out. For some people, it may be better than zero contact. For others, it's like, oh my God, one more Zoom meeting. Can I really handle that? I think I'd rather be by myself in my room. And in our study, what we found is actually 79% of the people we've surveyed had little to no internet and video usage per week. So that actually highlights that the ongoing digital divide among some of our populations and some of the economic barriers and discrepancies that still exist. And it really forces us as a healthcare institution to think about, as we move much of our care to digital, who are we missing in these visits, and what are the optimal ways to outreach to people medically, who pays for it? And then socially also, is that the right mechanism? Because we actually do not have data to support that as being a viable option yet.
In the study that you said you're doing, where some people actually have had less loneliness since the pandemic, was that people were connecting with them electronically, or were they connecting in real life?
So the most way that people are connecting are actually by telephone, and then very few in person, and then the least amount is by video right now. And I think, again, it highlights what Louise was saying that I mentioned yesterday, is that for some of our patients who are homebound already, they're already physically distanced and isolated to start with, and so they're not noticing that much change. However, what we are also seeing is some new unmet needs. So in our study, we also found that nearly 80% of the people surveyed actually were having trouble getting their medications, which again highlights this, what's going to happen a month from now, 2 months from now, 4 months from now in terms of chronic diseases. And we're also seeing that we have anywhere from 20 to 60% of people who are having difficulty finding help for their activities of daily living. And that's either because of workforce shortages, fear of families and patients themselves to allow people into the home. And we're seeing this also in long-term care settings where some of our patients who reside in assisted livings, the policies are of not having family members come in, and in some cases, not even allowing hospice agencies and other healthcare workers to come in for fear of what's going to happen in these locations. So a wide range of downstream effects.
Yeah, that's a good segue to Charlene, and let's talk a little bit about it's sort of hard to lump it all into one category of, I'm sure people tend to, skilled nursing and nursing homes and long-term care and all that, but tell us a little bit about sort of a similar question, a little bit of a primer of kind of what we should know about these facilities in America, and then a little bit about what's happened in the year of COVID in them.
Well, I think of the 100,000 people that have died, we have to remember that 37% of those have been nursing home residents, which is quite shocking because they represent a very small percent of older people live in nursing homes. So they are very vulnerable because they're frail, and they've certainly become more vulnerable during this pandemic because of the fact that visitors were prohibited and ombudsmen were not allowed in. And nationally, the inspections of nursing homes were essentially stopped. And so the virus has spread rapidly through a number of nursing homes, and they were totally unprepared for the virus. We know before the epidemic that 3/4 of nursing homes did not have enough registered nurse staff and enough nursing personnel. And so we've just finished a study of California nursing homes, and we found that nursing homes that did not have enough registered nurses in terms of what we think of professional standards should be, they were twice as likely to end up with residents that had the COVID virus. And so they were unprepared and unable to handle infection control practices. And before the virus hit, 67% of nursing homes had received violations for infection control, which is known to be one of the most serious problems in nursing homes before the virus.
And so that was in California, that 2/3 of the nursing homes in California had violations around infection prevention activities.
Yes. And they did not have enough staff, especially registered nurses. And so we know that the nursing homes that have the most staff tend to be the hospital-based nursing homes and the nonprofit nursing homes. The for-profit nursing homes tend to cut corners on staffing, on wages, and benefits. And so they were less prepared and more likely to get the virus.
And I know some of the work you've done has led to some of the regulations that exist in nursing homes. It sounds like you believe that the regulations as they currently exist aren't strong enough.
Yes, it's clear that we have lots of good regulations, but the staffing regulations are essentially inadequate. Mm-hmm. And so in the future, we're really going to have to address this. We can no longer let this happen. I think we're going to have to really rethink post-acute care. and try to do everything we can to send people home with enough professional staff and support staff to keep them safely at home.
Let me ask the others about this. So there's an issue of, can we make nursing homes safer? And then the second issue of, can we take people who right now go to nursing homes and figure out another strategy for them to not be in an institution, but to be at home? Is that your take on this?
Yes, and if we could get some of them discharged, that would be a good idea.
Discharged from the nursing homes.
Yes.
You mean in general, or you mean today because of COVID?
Because of COVID, but in general, I think there's a certain number that could go home if they had adequate support services.
So Carla, let me sort of throw that to you, because I know you work in settings. And you see this on the ground as a clinician. How does that all feel?
Yeah, so I think two things I want to highlight. One, I think that the nursing home focus is really important, but there's the other part about the other living settings where a vast number of older adults live, which are assisted livings, where the regulations are even slimmer and harder to even get data. If you look at guidance around the country from CMS, CDC, they're very broadly encompass long-term care together, or SNF, skilled nursing facility specifically, which leaves our assisted living very vulnerable, and even more vulnerable in terms of they're not getting any federal or state support for testing or for infectious disease. And so how do we support our patients there? In terms of this idea of supporting people at home, so we have a very robust care at home program, which takes care of homebound older adults for long-term primary and palliative care needs. There are models all over the country that show that this is a safe and cost-effective model that can be scaled. The question is that is just the medical component. So there's absolutely models to show how people can come home safely. The challenge is the additional support system. So it's the assistance with daily living, it's the nursing support. And again, there are models for hospital at home across the country that we can adopt, but we are in a budget crisis here in California, and we have seen just in the last week proposals by the state to unfortunately cut many of the services that allow our patients to stay home safely, and that are adult day health centers, that's in-home support services, which provides assistance to our patients who receive Medi-Cal, as well as MSSP, which is case management. So in order to be able to safely discharge people at home, it has to really be a comprehensive view of the medical, social, and functional needs of patients.
And you know, in the current setting, I know there are families who had their older relatives in a nursing home who thought about taking them out. Do you think that COVID will change the dynamic here going forward when this is all over, as people think about where should my parents be?
I think it will. I think the challenge, and I think our surgical colleagues are seeing this on the inpatient service, is seeing we want to operate on people, but we have to make sure that there's a safe discharge plan, whether in a nursing home or at home. But again, it's, you know, I think there can be very well-meaning people that want to keep people at home, but it's, you know, if you don't understand what it means to transfer someone who's non-weight bearing from a bed to a commode, that may be an even unsafe situation. So how do we support people? And so it's getting the right resources in place. I do think the conversations are changing. I've certainly had some of my patients in my practice at home who are getting ready to want to put their family member into long-term care and are rethinking that. Mm-hmm. And suddenly a hospital bed and commode is like the new solution. And so there are some creative ways to start thinking about this.
So Charlene, you wanted to comment on that, and then I'll ask Louise to sort of weigh in on the balance between home care and institutional care.
Well, I certainly agree with what Carla has just said, you know, that we really need to work out ways to keep people at home if at all possible. And I'm quite concerned that there's been an effort to increase funding to nursing homes because of concern about the deaths, which is totally understandable. But there are no strings attached to these proposals in terms of the nursing homes having to increase their staffing. And we need to have these programs at home. So I think this whole virus experience will definitely change how we're going to look at post-acute. And I'm hoping that maybe hospitals will step up and develop more post-acute units so that patients can be taken care of safely when they need institutional care.
Well, the fundamental problem, it seems like, as usual, is money, and that the business of either home care or institutional care for older people is not lucrative, and so nobody really wants to do it. And so part of the question is, will this spur an increased investment in this part of taking care of these citizens?
Well, there's a huge amount of billions of dollars being spent on nursing homes, but most of it does not get to the nursing care. Only 35% of it goes to nursing care.
Interesting.
So it's being siphoned off primarily for profits and administrative costs. So if we would do a better job of regulating financially, that would help too.
Right. Louise, why don't you sort of weigh in on this whole question of where people are and how this might change post-COVID?
Well, I think we've known for decades that we can keep people at home even when they require nursing home level care. Actually, the first big demonstration project took place in San Francisco. It was called Unlock and led to the Program for All-Inclusive Care of the Elderly. This, like so many programs for older adults, was shown to be cost-effective and effective and preferred by providers and preferred by patients and preferred by families. And while there has been some uptake, it has been complete. If this were a drug, it would be on every street corner, which happens very often with what we see in elder care. And I think this also speaks to your question of money. We act as if our hands are tied, but we're all part of the problem, because we also know that primary care is the bedrock for a high functioning healthcare system, right? The United States healthcare system, according to the World Health Association, comes in number 37th. Almost all the ones who do better than we do are reliant on primary care. And what do we have? We keep building up. Like you get paid the most if you work in or are in the ICU. More if you're in the hospital than in the clinic. We literally fiscally incentivize the kind of care that everybody hopes not to want and that is hugely expensive. And for that amount of care, and it's crazy, like Medicare will pay for a frail older person age 98 with advanced dementia, heart disease, an untreated cancer to be in intensive care for many months, but they won't give that person a few years earlier a hearing aid. Right? We think of intensive care as medicine and as a hearing aid as like a social perk. And yet, if you look at people with hearing loss, their health outcomes start to dive, their cognition dives. There's so many ways in which we have a robust evidence base that we're not paying attention to and that could make all this more affordable.
Explain the politics of this to me, because in every political battle we talk about, you need the older people are the ones who vote and got to get the older people on your side. And yet this is evidence of, sort of an underinvestment in and a sort of misallocated investment in a population that is large and growing and in most walks of life politically powerful. So I don't get it. Do you?
I think there are many, many components to this. In the first place, it's a large population, but still nationwide, it's only 16 or 17% of the population. So it's growing, and we've all seen the figures where it becomes much more significant. I also think this speaks to the internalized ageism I was talking about earlier, where older people are sometimes the higher. If you see the people who are still more robust, often will vote against the more frail. In that way that people who are closer to a group that is less socially privileged than there's abundant sociological and anthropological data on this, that the closer you are to the risk category, the more you're likely to exert the prejudice. So older people don't always vote. You can see this with AARP, which used to be the American Association of Retired People. It was focused on older people, and now they're really focused on people in their 50s and 60s. When they have pictures of people in their 70s, I didn't look that good at 20. So, they're really aiming at this market where I'm going to look good and feel good forever. So I think that's part of it. I also think there's a lot of politics to it. The people in the boardrooms deciding what we were going to pay for medically didn't include anybody from primary care or generalist specialties until just recently. So we stack the deck and then we act as if changing it isn't possible. And I actually think one of the most exciting things about COVID has been that we saw UCSF and other institutions change fundamentally in days to weeks. And I think previously we all said the healthcare system can't change that much. We can't repurpose what we do. We can't restructure. Well, now we know we can. And so I think we should.
Right. We only have a couple more minutes. I guess I'd be interested in any of you sort of talking a little bit about international comparisons and, are there other countries that do this really well? What are the lessons from them, whether it's around loneliness, whether it's around nursing homes or home care or around ageism and how they treat older people? You want to tackle that?
Well,
Yeah.
Go ahead.
Go ahead.
Go ahead. No, go ahead.
Well, I could just say I've done a lot of work in Norway, and I'm extremely impressed with the Norwegian nursing home situation because they have very nice nursing homes that have single rooms and are organized in small units, and they have high staffing. And these nursing homes are owned and operated almost exclusively by the municipalities. And the politicians there actually say, well, we want to invest in nursing homes because we expect we might have to go there and we'd like to have a nice place to go. And you would never hear a politician in the United States say such a thing.
Right. That's amazing. It sounds like your kind of fundamental belief is that the for-profit system does not work well in this sector.
That's definitely the case.
You should look at the graphs, Bob, in Charlene's work, because you can see that health outcomes correlate very nicely with whether you're for-profit or not for-profit.
Yeah.
And that speaks to also what you just said, Charlene, because looking back through history, you can see that across, I wasn't able to look for the whole country, but across Asian countries and European countries and North America, when either the state or nonprofits, often religious nonprofits, were in charge of elder care, generally it went much better than when people were trying to make money off lives. And I think I just have to add here that the lives being diminished are as much about the workers as the residents. These people are grossly underpaid. Their risk is outrageous. They are mostly brown and black-skinned people. And when we talk about this pandemic, we often divide the groups at risk into people of color and old people. And the intersection is complete, and it's the going back and forth in communities on public buses and in crowded areas where people live in poverty and in nursing homes. And it's the same people. It's the brown and black people who've been disenfranchised their whole lives who are in the worst nursing homes where they are dying in great numbers. And it is brown and black people who are working for almost slave wages at some of these places. So we can't divorce these medical issues from their social underpinnings.
Yeah. Carla, you want to?
I think, Bob, yeah, I think the other thing to note about international comparisons is that we do have models from Europe and, for example, the United Kingdom, where there's a better integration of social and medical services. We see that in the United Kingdom with the Coalition to End Loneliness, the appointment of a minister for loneliness, and we're seeing active social prescribing, which is really this idea that as a clinician, you can prescribe a social intervention, assuming you have evidence to do that. I will also say that the other thing that we've learned internationally is that I was reviewing some of the literature and the guidance from Australia on elderly homes, which really would encompass what we have here as boarding cares and assisted livings. And there was absolutely an early focus on the effects of loneliness and isolation, number one. And number two, there was a recognition that older adults are presenting differently with COVID, which I believe, and I think many of us in geriatrics believe, that probably contributed to some of the early cases and mass spread. It was only a week ago that the CDC finally included things like confusion and changing cognition to the definition and the symptoms of COVID. And so without some of these subtle findings, it is understandable that some of these long-term or other congregate living facilities were saying people were asymptomatic, when in fact they really weren't asymptomatic. They were very classic geriatric syndromes that weren't being picked up. And that's what we're learning from our international colleagues.
But this was identified very clearly in Italy in February, in the United States in early March. And it was really hard to get anybody to pay attention. We are very grateful that UCSF did listen to us and added it, but we have been the exception, not the rule on that front.
Got it.
Mm-hmm.
So Louise, let me give you the last word to, can you end on a hopeful note in terms of what you think this may do toward attitudes toward older people? Is there we've seen different groups that have been disenfranchised through history, that sometimes cultures change and things change, and sometimes pandemics are the things that do it. So anything about this that may lead to a different world when it's over?
Oh, I hope so. I think older adults and aging have never gotten more attention. And that's a good thing. And I think if we can all capitalize on it, one of the things we're working on a big philanthropy funded project at UCSF is really making older people part of the solution, because there are generations of old age. But I also think this is a family issue. If you feel outraged when you hear these statistics, you can make a difference. I feel like none of us make it to adulthood without knowing something about how to take care of children. And we feel that responsibility. If you don't take care of your children, you go to prison. Why is it okay not to do the same for your parents and other older people that you love? So we can do this in our daily lives. And we can also question some of the things that people tell us are the way they have to be. We've heard in the last half hour that it doesn't have to be that way. We know what to do differently, and we should just do it.
Great. Well, let's end with that, and it's inspirational. And I think about my 90 and 84-year-old parents in Boca Raton isolating, and it's really a daunting problem, but one I think you've given us some things to focus on and some hope. So thank you all for doing that. Really appreciate it. Let us to Antonio. So this is going to be definitely shifting gears. We're going to be talking about the world of the intensive care unit. And which has its own set of extraordinary problems that we're facing in the face of COVID. So Antonio, if you can come on, there you go. Nice to see you. Thank you for coming. So Antonio is Associate Professor of Medicine and works the ICU at Zuckerberg San Francisco General Hospital, which, as I mentioned, has had really a very impressive experience in dealing with COVID since the start. So I think you're going to give us a short talk, and then we'll chat after it. So I will. The screen will come up with slides, and it's yours.
Well, thank you very much, Bob, for the opportunity to tell everybody our story. My hope, we can go to the next slide, is to sort of provide you all a background in terms of where we were prior to the pandemic here at ZSFG, what our preparations were, what we did early on in March and through April, and bring us to the current point. And then we'll end with a little bit of the outcomes, and hopefully I'll be able to take your questions at the end. I think any discussion about what we did here has to start with what was the climate, what were we feeling before we got our first patient at ZSFG. And by now all of us know that COVID-19 can cause severe respiratory failure. And based on some of the early data that we were hearing out of Europe and China, mortality rates were very high, and in some cases exceeding 80% in ventilated patients. Other reports that were out there, some peer-reviewed, some not, were also indicating that folks were using, some centers were using some therapies in ARDS that had failed to demonstrate benefit in previous studies in the pre-COVID era, not in the sort of COVID-19 ARDS patients. And that was all sort of filtering around. We were hearing this from our colleagues across the world and seeing it in various reports. Also, social media was amplifying many things, both good and bad, as social media is capable of doing. But of a lot of observations around the globe, some of it peer-reviewed, some of it not. And then another thing that was sort of, we were feeling, but I'm sure every other institution was also feeling, was dealing with shortages of PPE and equipment shortages, or at least the threat of that, and having to ramp up our supply chains to provide the best care possible to patients and safety to the staff. Next slide. This is a busy slide. I'm not going to go through the entire thing, but this is sort of brings us from the end of February into March with a couple key points here. And my point is not to have everyone look at the slide and understand everything, but is to sort of point out that we had our first patient arrive at ZSFG to the inpatient unit on March 10th. It wasn't until 2 weeks after that where we got our first ICU patient. You can see that on March 23rd. Also on this graph, I want to, which I think is really important to show, is all the various innovations that we attempted, and all the various small tests of change that we did at ZSFG to enhance our care, both incorporating what we were learning in the moment from our own experiences, but also externally, and sort of the processes that we took to examine the external information we were getting and incorporate it into our daily workflows. You'll see also in there the green stethoscope, sort of our markers of where we underwent more training for nurses and sort of onboarded more nurses. You'll also see these sort of light bulb, the yellow light bulbs are sort of the little innovations that we did. I'll talk a little bit about the IV pumps and swim teams and things of that sort. And then the other thing that really has to be highlighted in any discussion of what we did and how it affected our outcomes are the two sort of blue hammers up in the upper left there, looking at sort of what the public response, the public health response and the response from the mayor's office about ensuring shelter in place and all that stuff that happened early on in March before we even got our first ICU patient. Next slide. So what did we do? I've sort of gone over what the climate was or what we were feeling at the time. Obviously, we had our incident command center up and running twice a day, just like everybody else, other institutions I'm sure did. But our basic approach to taking care of these patients and getting ready for what we thought was going to be a massive surge was we wanted to have a robust way of examining external information that was coming in, whether it be peer review, case reports, things we were hearing from our colleagues, how to rigorously examine those things and also be able to be adaptable to what we were seeing in our own patient population and what we were seeing in our own experience to change care. And so with that in mind, what our approach to taking care of these patients was we were going to stick to the evidence-based ARDS management for these patients, meaning we're going to stick to low tidal volume ventilation, early proning, and a very conservative fluid management when we were able, meaning no excessive fluids and diuresis. These are all sort of basic tenets of ARDS management, regardless of the etiology. And so we wanted to take that, what we knew from that, and bring it into the COVID-19 ARDS environment. We also wanted to make sure that we didn't undergo or administer any therapies that were not supported by high quality evidence. And there are various ones out there, at least that were being made evident at the time, that had not been vetted rigorously in the literature, in peer review, or in studies. And so we were not choosing to go in that direction. But at the same time, we also had a firm commitment from our staff and from our institution to participate in clinical trials. So as an example, we were in the remdesivir, the early remdesivir trial. We were in an enrollment center and enrolled quite a few patients into that study. Also, mesenchymal stem cells. I think both of those therapies we've heard about before in this venue right here. So that was our commitment to examine sort of good candidate therapies in a rigorous clinical trial. And any major practice changes, we all agreed to rigorously vet them and debate them amongst the faculty before instituting them in a widespread manner. That's not to say that faculty didn't have some latitude to try something if they thought it would benefit a particular patient. But before we would institute it across the board, we definitely underwent a vigorous vetting process, including not just within our division, but also external to our division, and bringing in experts from hematology or surgery if we were debating certain things like VTE prophylaxis, which we'll get to later on. Then also we adopted sort of some practical innovations that I'll get to later to help limit the spread of virus and to preserve PPE. And then finally, one of the things that we invested in heavily early on was increasing our staffing of nurses, respiratory therapists, and physicians. Next slide. So this is a slide that perhaps many of you have seen in various forms. The small inset blue graph is the experience in San Francisco to COVID in terms of the total number of cases and total deaths. And then the larger graph there is our experience here at ZSFG. And you can see that it basically mirrors the experience in San Francisco. At the time of this production of this graph, we had taken care of about 172 patients, inpatient in the hospital. That includes inpatient and ICU. And then you can also see the mortality count there as well. Next slide. Now, drilling down into the ICU, again, you can see here that our line very closely matches that of the hospital and the city. You can see that there's a big slope there at the late March, early April. And as Dr. Rutherford's models predicted and others' models predicted, we had our peak census sometime around April 13th. And it's sort of, even though our overall numbers have increased over that time, the basic census, which I'll get to later, has sort of come down over time as well. Next slide. This is sort of a description of, where did our patients come from? What was the demographic of our patients? As you can see, it was mostly male, and a large proportion of Latinx patients. 73% of our patients were of Latinx descent, which, as far as I know, is not reported really anywhere else in the literature that I can see. Our age distribution was a little bit younger than many other centers. We were in the sort of 40 to 60 age range were the majority of our patients. And then the preferred language, something that, we're always focused on. And even though I'm not going to get to it in this discussion, maybe it'll come up in the Q&A, communicating with patients and patients' families has been a major challenge for us, and I'm sure for other institutions, especially with the visitor restrictions that are in place. Next slide. So when we talk about ARDS management and the management that we undertook for these patients, it's important to break it down between the pre-intubation period and the post-intubation period. So in the pre-intubation period, this just gives you a snapshot of what we saw. About 63% of our patients required mechanical ventilation. The mean time to intubation was 12.5 hours from the time that they arrived to the ICU. At the time of intubation, almost all the patients were on some form of high flow nasal cannula. And unlike other centers, we didn't limit our liters per minute flow to 25 liters. We allowed the clinician to go as high as 40 liters per minute as needed. One of the considerations there was a spread or the concern for spread of the virus to staff or anyone in the room. But we all had appropriate PPE before entering in that situation. Next slide. So in the ventilated period, this is the slide I'm sort of most proud of the work that we've been able to do. And it's that 100% of our patients who were ventilated with COVID-19 ARDS were on the ARDSNet protocol to a T. And what I think is most impressive is that we were able to get the patients down to 6 cc per kilo, which is the target tidal volume based on ideal body weight, under 2 hours. Just as a frame of reference, our historical non-COVID-19 controls were sort of in the 8 to 16 hour range for those patients. The average PEEP, positive end expiratory pressure, was 10 with a range of 8 to 12. Driving pressures was another interesting point here. That is the plateau pressure minus the PEEP, which we know is linked to independent predictor of mortality, was 13, which is fairly good. For patients with ARDS. And then also our average tidal volumes, we were able to get them down and keep them down in the 6 cc per kilo of ideal body weight, which is exactly where you want to be. The one other interesting thing about these patients is that they were much easier to ventilate in comparison to historical controls of other etiologies, and that's the graph off to the right side there. You can see for the COVID ARDS patients, minute ventilations for these cases, for these patients were in 7.8 liters per minute, which in comparison to others was much lower, and that was statistically significant. So just a little bit something interesting there. I have some theories, but I'm not going to share them today on this. And then also the PF ratios were also very low for these patients, sort of all in the sort of moderate to severe range. Proning was something that we did quite a bit of here and quickly and aggressively early on. About 60% of our patients received some amount of proning during their course, and the median time to proning was a quarter of a day, which is incredible, and I think speaks to the true dedication of the staff to get in there and get fully donned in their PPE and PAPRs in some situations and just get the patient where they need to be. The mean duration of proning was also an issue as well. Next slide. The experimental therapies, these have been discussed in other venues in this particular venue, so I'm not going to go too much into them. Except to highlight that we did not institute corticosteroids on these ARDS patients, as had been suggested in some of the literature prior to receiving our first patients. Next slide. This is an example of what we did with the VTE prophylaxis and incidence in our hospital. So almost everyone got some form of VTE prophylaxis ordered. And we had, an increase in the rate of VTE number of patients. We had 9 patients out of the 43 in this particular group that ranged anywhere from pulmonary emboli to DVTs to strokes. And so we use this information to sort of decide as a group, should we change the way we do VTE prophylaxis? And this is just one of those examples where we got together as a group led by Dr. Carolyn Hendrickson and Lucy Kornbluth from surgery to examine the literature up to that point based on our past experiences as well as our current experiences, and decide what to do with our VTE prophylaxis. Next slide. So this is an example of our efforts to try to limit the spread and conserve PPE. So here we have swim teams and putting the IV poles on the outside. So I'll start with the IV poles on the right hand of the slide. You can see there that every room is private with a sliding glass door. And outside of that door, there's sort of these giant Christmas tree-like structures of IV poles and IV pumps on the outside. And that was to allow nursing and staff to make changes to drips without having to fully don in PPE and go into the room unless needed. Or if a nurse was tied up in the room with the patient, they could call out to another nurse, support nurse, who could change the pump settings without having to enter the room. And then the swim teams, which is something that we're extremely proud of. On the left-hand side, you see a group of nurses attempting to prone the patient or starting to turn the patient fully donned in their PPE. And what they would do is they go from room to room, and we'd schedule the proning in such a way that you could get donned in one set of PPE and then just go to the next room and turn the next patient and turn the next patient and go on with more patient care. So next slide. This is another example of us attempting to cohort patients. We cohorted patients in 2 10-bed units. So we had 10 bed or 20 beds available. And as the pandemic progressed, we were worried about surges, so we had to increase our capacity to the point where at one point in early April, we were concerned we were going to exceed our capacity. We got up to about almost 80 beds that we could have used. We never got there, but we were ready for 80 ICU patients if we needed to. Next slide. And this is also to highlight the staffing increases that were made. The dotted line on this slide will show you sort of what our overall ICU census, so that includes COVID and non-COVID infected patients. So you can see it trending up in early April there, and our nursing staffing increased to match that. Next slide. This is our ventilator use. We had 67 ventilators available at the start of the pandemic. Again, we never came close to using that. We used about 25% at our peak. We also ended up finding more ventilators to put into our fleet. It got us up to about 78 by the end of the pandemic. Next slide. And then our physician staffing, we had dedicated teams that would take care of 10 patients apiece. Each team was staffed with an attending during the day and attending at night. During the peak of our census, we had 2 teams running, so we had 4 attendings, 2 during the day and 2 at night, also with a critical care fellow and 2 residents from internal medicine and anesthesia that were participating in the care. The other part of the physician staffing that we had was an anesthesia strike team. So a strike team, an anesthesia team that was ready to go, well-versed in PPE and donning PAPRs, who would go in, intubate the patient, assist with line placement, and then would come out of the room, which again freed everybody up to take care of the other patients and also limited the spread among staff and amongst other patients. Next slide. So going on to our outcomes, next slide. Here's what happened. So at the time of the production of this slide, we were up to 50 cases. 30 of those patients were intubated, and 16 of those patients were proned. And another 10 of those received CPVH during their stay. You can see on the right-hand side the ventilator days. The blue are the COVID positive patients, and the green are the non-COVID patients for the same time period. You can see obviously like very long vent days by mean and median in the COVID positive patients as opposed to the non-COVID. And then length of stay also, not surprisingly, very prolonged for our COVID patients. Next slide. This is a snapshot of what has happened to our first 50 patients. So you can see that the majority of them have been discharged to outside of the hospital. So whether that be skilled nursing facility, home, one of the hotels that was sort of used by the Department of Public Health to quarantine patients. We have had 6 patients who died. Another 10% of them, of our patients have been transferred to outside hospital, Kaiser and St. Francis. And several of them are still on the med-surg unit. And right now we have 6 patients in our ICU. Also on the right, lower right-hand side, you can see the hospital length of stay, again, very prolonged for the COVID positive patients. And just as a, to put that into context, that is just the patients who came to the ICU. That's not all comers to the hospital. Next slide. So this is my last slide, but just to acknowledge everybody who participated in the care of these patients. Obviously, we couldn't have done it without everybody on this list involved. Just a special recognition to Joy Capiccio, who was our QI nurse, who put together a lot of the slides and the data for this. And even though we were all very busy, we still kept going with our sort of QI and PI processes and evaluation as we normally would under normal times. So with that, I think we'll stop for questions.
Great, Antonio. Thank you so much. That was fascinating. So in terms of the ultimate outcomes, you're already at 56% survival, at least to leave the hospital, and probably the ultimate number will be somewhat better than that because some of the other people in the hospital should leave. So it's better than the reported outcomes elsewhere. What do you think that is about? We've spoken to some of our colleagues who went to New York and talked about situations where they had ICU patients in the recovery rooms and one nurse for 7 ventilated patients. Do you think it's just a matter of workload and sort of chaoticness that makes the difference, or do you think there are other things?
I think it plays a large part in our outcomes. We had time to prepare, so we weren't really caught by surprise necessarily. And also just the basic social distancing efforts that have been made throughout the 5 counties in the Bay Area, really helping to limit the spread, allowed us to really bring that peak down so that we could better prepare. And again, we still, obviously, there was a source of tremendous anxiety. Do we have enough ventilators? Do we have enough beds? So we turned the PACU into an ICU. Fortunately, we never had to go there, but we had that ability if we needed. But again, as you know, having the physical space is different than having the actual, human resources to actually care for the patients in a normal ratio, normal nursing and physician ratio that we would all like. So I think we were just really fortunate that that we never came above the sort of like danger nursing ratio or physician ratios.
And one of the folks online asked about the proportion of Latinx patients in the ICU, and you mentioned that sort of a disproportionate number are coming in the hospital, have COVID, come to the hospital. Is that true in terms of your ICU census as well? And do you have any sense of any differences in outcomes of patients based on race and ethnicity or any other sort of predictors of who's going to do well or poorly?
No, I can't stratify the data based or our outcomes based on that. But that 73% has been pretty consistent since the very beginning of the pandemic for us, not just in the ICU, but also in the hospital. So those numbers I presented, those are the ICU patients. Those aren't just the ward patients. And lots of potential reasons for that. But that's what we're seeing.
Talk a little bit about proning, and first of all, how important has that been in the outcomes, and how does it what's the process of flipping a patient over when they're intubated and they have 10 different IV lines coming out of them? How long do they stay prone? And then what's the mechanism of if it does lead to an improve, I can get that they're going to do better for a period of time if it helps in terms of the aeration and the way fluids distributed. But why would that lead to a difference in ultimate outcomes if it does?
Yeah, so the main driver of doing the proning for ARDS patients was the Perceiva trial from a few years ago, published in the England Journal. That was ARDS of all comers, but starting proning within the first 24 to 48 hours the patient arrives. The theory there being that if you can limit the amount of damage that the ventilator itself is doing to the lungs by improving oxygenation and ventilation, that you give more time for the lungs to heal, essentially. That's the prevailing wisdom on that. So we just extended that to our COVID-19 population. I don't think we have the N to basically say the number of cases to basically say that, if you get prone, you do well. I mean, to some degree, proning is a marker of how ill you are, right? How sick you are. So because we were sort of proning anyone with a PF ratio less than 150, and we were doing the proning or proning the patients for as long as we needed, it's hard for me to sort of say, well, the patients who were prone did better or not. All of the patients who eventually did pass away, with the exception of one who actually never got intubated, were prone at one point during their stay. But we've had many successes, obviously, as well.
How long do they stay prone for?
So our protocol is at least 16 hours in the prone position, but even up to 20. That is our goal. But we've had many patients, including several patients that we currently have in the unit, that they do so much better prone that when you do flip them back over on their back to do routine nursing care, check IVs, check x-rays, they can only go 30 minutes before they have severe hypoxemia in that position. So we try to get everything done that we need to get done in that moment, echoes, x-rays and things, and then we put them prone again. For whatever reason, many of our patients just do better in that sense.
How long does it take that team to get someone from being on their back to being prone?
Yeah, it's really an amazing effort. We've been doing manual proning at the General for at least 5 or 6 years now, and some centers use a rotoprone bed that does the proning for you essentially. But the manual proning we found is just something that is easier for us to do. We don't have to wait for the bed to arrive. We can just actually do it. It takes about 10 to 15 minutes to actually do the proning because there's a lot of preparation you need to do with the lines and tubes and such. There is someone usually at the head of the bed, maintaining the airway, and someone at the foot of the bed reading off the checklist. And we do this for pretty much every patient just to make sure we don't miss anything, that's the checklist that we follow. So it takes about that time. It actually probably takes longer to get donned up in your PPE and then taking the PPE off than actually doing the proning, but it's still a pretty labor-intensive maneuver.
Just have time. I'd assume, is there a hole in the bed where the patient's face goes, or?
No, we put pillows. We use pillows. The patients sort of their heads are off to the side. One of the reasons we call that team the swim team is because when the patients are face down in the hospital bed, we have one arm up and one arm down, and then our protocol had been every 2 hours, we would turn their head and move the arms. That's a sort of a way to relieving the pressure on the skin. So it was sort of like swimming, if you will. That's sort of why we came up with that.
And for a couple more, so somebody asked the functional status of the people who are leaving the ICU. Are these people still having problems in terms of neurological injury or just overall functional status?
Yeah, that's a great question. It's not a question I can completely answer today. Our hope, similar to the hope at UCSF, is to have a post-COVID ARDS clinic, way to follow these patients well past their discharge. But most of those patients went home, some with home physical therapy, and because our patient population was skewed a little younger than some others, their recovery is probably a little bit better. But there's no question many people left with sort of compressive neuropathies, some skin breakdown, things of that sort. But even, we had 3 patients here that were here the longest. They all walked out of the hospital.
Great. Last question for you is, I remember early on, it seemed like the prevailing wisdom was intubate these people really early, and then it seemed to flip to try not to. Where are we now?
Yeah, I think we are still in the here, anyway, we're still at the intubate a little earlier rather than later camp. Yeah, there was a lot of out there about, that the ventilators are causing death or causing harm. And there's no question that ventilators can cause harm. But I go back to the way we've been ventilating the patients and really adhering to the ARDS 60 cc per kilo, early proning, following the ARDS guidelines to a T as best as we could. I think that has really sort of limited any damage that the ventilator itself can do. So we're still in the innovate a little earlier rather than later, but it is true we have shifted a little bit to waiting a little bit longer because patients are doing so well with high flow nasal cannula.
Great. Well, thank you for all your efforts throughout this pandemic, and learned a lot from hearing you now. So thank you. I really appreciate it.
Thanks for the opportunity.
A pleasure. All right. Last speaker today is Chaz Langelier, who is Assistant Professor of Medicine in our Division of Infectious Diseases and has become a go-to person to teach all of us about testing, which seems to get more complicated every day. So Chaz, thank you for being here. Chaz will give us a short talk for us, and then we'll have a little Q&A afterwards. Thanks for being here.
Okay, absolutely. Thanks, Bob. So when we first talked about diagnostic testing of COVID-19 at Medicine Grand Rounds back in early March, things were pretty dire. Access to testing was significantly limited. And we're in a much better place now if we look at the number of tests per 1,000 people, but still in many parts of our country, people cannot get access to testing. So we still have a ways to go before reopening can happen. Next slide, please. Really the central type of testing done for COVID-19, although more test types are coming out, is reverse transcriptase PCR that detects the RNA of the SARS coronavirus 2, the etiology of COVID-19 disease. And most RT-PCR assays target one or multiple of 3 genes, the E gene, which encodes the envelope glycoprotein, the N gene, the nucleocapsid protein, or the RNA-dependent RNA polymerase. Next slide, please. And really one of the key questions that a lot of people have for good reason is how well does RT-PCR testing perform? And while the answer is still not entirely clear, I think we can get an indication based on the likelihood of a test identifying disease. So this was a study done in Singapore of 70 COVID-19 patients using NP swabs. And they found that with a single test, they could pick up 88.6% of cases. 2 tests, they got nearly 96%, and 3 tests, they got all of them. And here they used, of course, a gold standard of NP swab testing, so this really doesn't answer the question, but it tells us that 1 test probably gets most cases and 2 does even better. Now, what causes this type of variability? Next slide, please. Well, certainly one reason is sampling technique. It's not as straightforward as some may seem. And in fact, you can brush up on your NP swab technique, perhaps over a Corona this evening after dinner by looking at this New England Journal of Videos in Clinical Medicine. But there can be quite a bit of variability, and presumably that contributes to some of the suboptimal sensitivity. Another key aspect, next slide, please, is timing. This was a study that recently came out that did a composite analysis estimating the raw sensitivity from 7 different papers that tried to address this question. And really, I think one of the key take-home messages here is that early during disease course after symptom onset, sensitivity is highest. Fortunately, one of the disconcerting conclusions from this paper was a high false negative rate of RT-PCR testing. When they looked across the median sensitivity, the best sensitivity that they identified in terms of median sensitivity at the day with the highest sensitivity was 80%. And that translates into a 20% false negative rate. Now, that conclusion is not different in many ways from what people have seen with respect to other viruses, but many may raise concerns about a 20% false negative rate. Next slide, please. And I think really an important thing to think about when we're discussing COVID-19 diagnostic testing is the negative predictive value. And it helps put into context what a 80% sensitivity means. So the negative predictive value, you may remember, is the probability that a negative test actually means the patient doesn't have the disease. And there's the equation for you. And one thing you'll notice in the equation is prevalence. And so the negative predictive value is affected by prevalence. And that's really an important thing to keep in mind. Next slide, please. So this means at a 1% prevalence of COVID-19 in the population, which might be a reasonable estimate for the Bay Area, if we're talking about an 80% test sensitivity, that translates to a negative predictive value of 99.8%. Even if the test was no better than flipping a coin, which some studies have suggested, you still get a 99.5% negative predictive value. Now, in terms of our test positivity at UCSF, we're looking in the 3 to 4% range, but let's say we're talking about a 5% prevalence. Even if you estimated a 50% test sensitivity for your COVID-19 test, your negative predictive value is going to be 97.3%. So this is just an important thing to keep in mind and to place things into context. Since you're probably salivating to learn more, let's move on. Next slide, please, to talk about saliva testing. There's been a lot of press on this, and perhaps in one of the great face-offs of the last month, saliva has gone head-to-head with nasal pharyngeal swabs. This was a study out of Yale that found that saliva actually has higher viral load than nasal pharyngeal swabs, and that got a lot of people pretty excited until another study came out shortly thereafter that found the opposite conclusion. But I think the bottom line here is that there really wasn't a very significant difference between the two, and that saliva may be a reasonable alternative. Next slide, please. The question of upper versus lower respiratory tract sampling, I think, is an important one, especially if we're considering ICU patients. This was a study from a Hong Kong group that compared the two over time. X-axis is days, y-axis is viral load. And what you can appreciate is that there's higher viral load in endotracheal aspirate than saliva. Perhaps not surprising, since COVID pneumonia is a lower respiratory tract infection. Next slide, please. What about patient-collected testing? This has been an interesting development since the last Grand Rounds. There was a study by a group out of Washington that compared healthcare worker-collected NP swabs to patient-collected mid-turbinate swabs. And when they compared the two together, they did not see a significant difference. And this was a result that ultimately, I think, led to some changes in approaches and guidelines from the FDA and CDC to allow for initially clinician-monitored patient-collected swabs, an important development in terms of reducing PPE use from healthcare providers who otherwise would need PPE to do swab testing, and ultimately has led to a number of developments, including just recently the FDA authorizing the first standalone at-home sample collection kit that can be used with a number of authorized tests. Next slide, please. Of course, we have to talk about rapid diagnostics, and I've shown three general categories here on this slide. The first is our tried and true RT-PCR-based rapid diagnostics. So the Cepheid Expert platform that's shown in the picture, best known for detecting tuberculosis, can return a sample to answer in about 45 minutes. You swab the patient, you put the swab in the cartridge, you put the cartridge in the machine, and it gives you an answer with about as high accuracy as you can get for swab-based testing. Diasorin makes a similar type of product. It's used at UCSF, and that returns an answer in 90 minutes. Now, the other rapid diagnostics have been compared against RT-PCR gold standards. Perhaps one of the most controversial and one that's been in the news is the Abbott ID Now platform. This uses an isothermal nucleic acid amplification technology. It turns around in 15 minutes an answer. However, its sensitivity has ranged in reports anywhere between 50% to close to 95%. We'll talk about that in a minute. Specificity is good. More recently, just in the last 2 weeks, we saw the first antigen-based assay that detects a viral protein. This also returns an answer in 15 minutes, and the sensitivity there is 80% compared to an RT-PCR gold standard. Next slide, please. To make one additional comment on the Abbott ID Now platform, many institutions across the country purchase these platforms, UCSF included, and a lot of people were very enthusiastic. However, just recently the FDA released a warning about possible accuracy concerns with this point-of-care test. In particular, this warning was spurred by a study that's a preprint from New York University looking at 101 ED patients. They found the sensitivity was 51.6%, which essentially is flipping a coin. Now, of course, a study that was funded by Abbott came to a different conclusion with a sensitivity of 94.7%. So I'd say the answer is still out there in terms of how well these do, but this has been enough to result in many places not using this Abbott ID Now test, UCSF included. Next slide, please. Now, one important point and one interesting feature that has created a lot of complications is that patients can remain PCR positive for weeks. This is the same slide as before, and what you can see is that you can detect virus in all of the patients in this study beyond 20 days. And what does this mean? Well, this is a key question that we're trying to answer. Next slide, please. In fact, the question of what is the duration of infectivity is still not entirely answered, but really important. It has significant implications for infection control and for understanding transmission to others. Shown here are data from one of the earliest papers to look at a cohort of mild to moderately symptomatic patients in Germany. And essentially, one of their key findings was that after 8 days, no virus could be cultured from patients, despite the fact that they remained PCR positive. Next slide, please. More recently, there was a study in clinical infectious disease that came to a similar conclusion. So plotted here in the line is crossing threshold, which equates to viral load, and in the bars is the probability of culture positivity based on a model that they built. And essentially, they found that after 7 days, the probability was next to zero that a patient would have a positive culture. So even though people appear to remain PCR positive, they still have detectable viral RNA. They are not apparently releasing infectious virus or at least cultural virus based on these two studies. Next slide, please. So what potentially could explain this? Well, in the original Wolfel paper, they looked at the percent of patients who became seroconverted with a positive antibody test, and they found that this correlated with the loss of culture positivity, suggesting the presence of broadly neutralizing antibodies that may explain the situation. Next slide, please. So this brings us to the category of antibody testing when we're talking about COVID-19 diagnostics. And some very nice work by Alex Marson and colleagues that was discussed on last week's Grand Rounds. I won't go into it in too much detail. They really demonstrated this temporal dependence in antibody test positivity. You know, that's been known for much time with respect to other types of infectious diseases, but also holds true here for COVID-19. Within 1 to 5 days, the sensitivity was very poor for antibody tests. The different colors are different companies. But after 20 days, the vast majority of tests that they analyzed had relatively high sensitivity, although you can appreciate that there was a fair amount of variability between the type of tests used. And then shown on the right is the specificity when these antibody tests were assayed against patient plasma that was obtained before COVID-19 was known in the world. Next slide, please. So the question of antibody response in immunocompromised patients is an important one, and one that has been partially answered from nice work done by Monica Fung and colleagues in the Division of Infectious Disease. And this was a study that looked at 7 solid organ transplant recipients. And what they found, interestingly, is that despite the profound immune compromised state of these patients, all of them still were able to produce detectable antibodies. Now, you can appreciate from the slide that there was significant variability in terms of antibody production and ability to detect this, with some patients barely crossing the threshold, but nonetheless suggests that this type of testing has value in immune-compromised patients. Next slide, please. So SARS coronavirus is just one of hundreds of different pathogens that can cause lower respiratory infections, which even before COVID-19 were the leading cause of death from infectious disease in the United States and worldwide. And it can be mind-numbing sometimes just to think about all the different COVID-19 diagnostic tests, never mind all the tests that might be needed to detect all of these different types of pathogens. It seems improbably complex and impossible to have a test that could not only detect these pathogens and also any future ones that might emerge, until we appreciate, next slide please, that both pathogens and their human or animal hosts are connected by a shared genetic code and 4 nucleotides. Next slide, please. And that these can be detected with a technique called metagenomic next-generation sequencing. Next slide. Now, metagenomic next-generation sequencing is unbiased in terms of its ability to detect not only known but also novel pathogens. And in fact, it was this type of technology that allowed the world to understand that it was a SARS-like coronavirus that was causing this idiopathic pneumonia syndrome in patients in Wuhan. Next slide, please. Before I wrap up, I'd just like to share some exciting data from our collaborative Department of Medicine Chan Zuckerberg BioHub research group that leveraged metagenomic sequencing to study the host gene expression in upper respiratory samples from patients who were COVID-19 PUIs. And when we looked at differential gene expression across these patients and did unsupervised clustering, we found a very interesting thing. What we found is that patients with SARS coronavirus 2 infections had a unique gene expression signature in their upper respiratory tract. And that's that middle cluster here. And that differentiated them from patients with other types of viral acute respiratory infections that prompted COVID-19 testing, or non-viral causes of acute respiratory infections that prompted testing. Next slide, please. And we leveraged this gene expression data and used a machine learning approach to build a diagnostic classifier that could predict with high accuracy whether or not a patient had COVID-19 without ever having to detect the virus. And perhaps the most exciting result from this was that the performance of the diagnostic classifier was unaffected by viral load. Shown on the right on the x-axis is a metric of SARS coronavirus viral load, metric of reads per million identified by sequencing, and on the y-axis is the probability that the classifier predicts COVID-19. And you can appreciate that there's no loss of performance despite lower viral load. And so perhaps this approach of detecting the host immune response to SARS coronavirus, as opposed to depending on detecting the actual viral RNA, perhaps this approach will overcome the significant false negative rates that have been described for coronavirus RT-PCR tests. Next slide, please. And so I'd just like to end with one of the more uplifting stories in diagnostic testing when it comes to COVID-19. And this is work that's been done at UCSF and the Chan Zuckerberg BioHub to really expand capacity for testing. This is the CZ BioHub CLIA lab, and leveraging a team of volunteers as well as many other dedicated scientists and clinicians, they've built a capacity to test over 2,500 people a day and have done over 22,000 tests since March 20th. Next slide, please. And this has really allowed UCSF to truly serve the community in terms of providing accessibility to diagnostic testing. These are just some of the different hospitals and departments of public health that are now doing their testing part at the BioHub. We still have a ways to go in terms of being able to reopen the country and test people as frequently as it's needed, but nonetheless, this is an encouraging step forward. Next slide, please. And with that, I'll wrap up on our discussion of COVID-19 diagnostics.
Chaz, thank you. That was fantastic and a lot of information in a short period of time. And I'm going to pepper you with some of the questions I get all the time that you hinted at, but they're maybe a little bit more specifically. So this issue that you don't have live virus, but you're testing PCR positive leads to this massive conundrum when you're trying to figure out, can someone leave isolation? Can someone go home? Can someone go back to work? Can someone go back to grandma's house? All of these issues. So how do we decide? And I saw a study that said 11 days after symptoms, we're pretty sure you're not shedding live virus. Is that after you start having symptoms or end having symptoms? All this is still a little vague.
Well, I think taken together, the data thus far suggests that for the majority of people, 2 weeks after the onset of symptoms, even if you can still detect the virus, most people are probably non-infectious. No one has absolutely proven this, and without a doubt, there's going to be variability person to person. So I think until we definitively answer that question, I think we're bound to use PCR testing to look for viral negativity before we can feel entirely comfortable about taking people off of infection control precautions. All of that said, perhaps we'll have an approach in the near future where we can actually assess infectiousness without having to use viral culture, but we're not quite there yet.
Okay. And I assume that the flip of what you said is true. If your PCR tests negative, that then you are clear. There's no my PCR is negative, but I actually still am infectious somehow.
Well, that's a good point that you bring up. I mean, if we're talking about a potential 20% false negative rate of PCR testing because a swab was not obtained optimally, then really you need, I think, more than one test to be absolutely sure. I think you can interpret this in the context of multiple tests. So if somebody had a test that indicated a high viral load the day before, and then all of a sudden they're negative, perhaps that raises some concerns. So I think a generally accepted approach is to have 2 negative tests to feel good about someone truly no longer having detectable virus.
Say 2 negative tests. You're talking about the same test platform. It's just 2 different points in time, not necessarily different tests.
Exactly.
Okay. The sensitivity of the test in asymptomatic versus symptomatic people, does it matter?
That's a good question. It's one that hasn't entirely been answered. There are a number of studies now that have found that at the time of test positivity in surveillance studies, let's say a study of patients on one of the cruise ships, almost half of people were asymptomatic when they tested positive. We still don't know in terms of the likelihood of a test being positive or negative with respect to whether or not someone is symptomatic. We do know that viral load is highest earliest during infection, but if someone was just exposed the next day after they're exposed, the virus is not going to have had enough time to replicate and be present at significant levels. So I think it varies significantly depending on where someone is in terms of their disease course.
And is there, as I think about false negatives, let's say particularly early in the course, so let's say you have not built up enough virus to cross a threshold and be positive, so you're really a quote false negative, but I would guess, does that correlate with my infectivity? In other words, I'm negative even though I do have the virus in me, but I'm negative in part because I don't have enough virus to trigger the test. And I would assume that's somehow correlated to maybe I don't have enough virus to be at a high likelihood of infecting somebody. Do you know what I mean?
I think that's a line of logic that a lot of people have put forth, and I think makes sense. We don't absolutely know the answer to that yet. But presumably, if you have lower amounts of virus in your respiratory fluids, your likelihood of being able to transmit that virus to someone else, especially if you're not coughing, sneezing, or otherwise spraying the virus into the air, is going to be much, much lower.
Okay. For businesses and other entities that are trying to come up with a testing strategy that will prove that this person is safe to go into work or play Major League Baseball or get on an airplane. Clearly, just testing them once doesn't tell you anything. So how often should, let's assume the tests are available and it's feasible, what's the right periodicity of testing to be able to say this person is safe to come to work?
Very good question, one that's hotly debated. I think to answer this question, it is important to consider that negative predictive value. If we're talking about someone in the general population without symptoms of a respiratory infection, then the probability that a negative test means they actually don't have COVID is going to be really high, and they're probably safe to go to work. Now, someone certainly could get exposed the day after they get the negative test. If it's somebody who's traveling for business or for whatever reason and has a higher risk of exposure, then they might need to be tested more frequently than someone who is going to work and then just going home.
Well, what's the consensus of, okay, we want to test people frequently, we want to be as safe an environment as possible, and daily testing is not feasible yet. So we're going to do it once a week, twice a week. Is there some consensus there, or it's just once a day would be better and everything else is a little worse?
I don't think there's a consensus quite yet. I think it will, depend largely on the availability of resources and accessibility of testing. I think it'll also depend on whether we are able to identify an antibody test that actually informs us of immunity and informs us of someone's likelihood of being infected.
Yeah,
but
so
we're not quite there yet.
My last question, that you didn't address the question I think we talked about last time, which is the antibodies and do they equate to immunity? So what we've learned in the last month, there have been a number of studies that have sort of hinted at this, but where are we today in terms of being reasonably sure that if you've cleared your COVID infection, you develop antibodies that you are in fact immune?
I think we still don't know. I think there's still a lot of hope that we'll have an antibody test that tells us whether or not we're immune. But as of now, we're left with multiple antibody tests that tells us whether or not we've been exposed and been infected, but they don't tell us whether we're immune. So I think there is a lot of hope and belief that we'll get there in the near future and that this can inform safe working practices and many other things, but we're still not quite there.
And in your brief, we're going over a minute or two, but that's fine. Your brief Bayesian discussion, you didn't talk a lot about false positives in the antibody tests. And obviously there have been some controversial studies that said, see, the prevalence of this disease is much higher. I think most famously the Santa Clara study, where there was a lot of criticism that probably a lot of those positives were false positives because the prevalence was so low and the test wasn't perfect. Is that what's your thinking about that whole question of false positivity in the antibody studies?
Well, it's a big issue, but as Alex Marson's work demonstrated, there's quite a bit of variability across antibody testing platforms. The particular platform, an Abbott platform used at UCSF, is highly specific, at least based on studies from patients prior to COVID-19. But many other antibody platforms do cross-react with the common cold coronaviruses that normally circulate in our population. So I think studies like those from Alex Marson are going to be important to really help us understand in context what a given antibody test result means based on the performance of a given antibody assay.
You didn't, maybe last week, you didn't note that the most famous use of the Abbott test, I guess every day, was in the White House. Do you know if they're still using it?
As far as I know, they're still using it. So what that means, I'm not sure, but I think we could think about a number of scenarios.
Yes, I'm sure we can. We'll stop there. Chaz, thanks so much. And thanks everybody for staying with us. So maybe we'll pull up the last slide and just thank you all for being with us. We had around 1,000 participants today. The crack production team is shown there on the slide. They are terrific to make these Grand Rounds go seamlessly. We'll come back to you next Thursday with more, and we'll keep doing it until there's not enough to talk about, but that doesn't seem to be the issue. There's so much going on. So thanks, stay well, and we'll see you next week.